let's talk about now the first question, which really comes down to sequencing, right? So the decision of, is this patient a good candidate for PARP inhibition really means the sequencing. So I'm going to create some clinical scenarios and bounce them off you. And the first clinical scenario is probably the most common clinical scenario. So a patient who is, and I'm going to try to speak generically, a patient who develops a platinum-sensitive relapse, okay, and is Bev naive. That's really the most, and is BRCA negative. That's the most common scenario, because most patients don't get Bev up front, and most patients don't have a BRCA mutation. And in that group, which is the most common scenario, in the platinum-sensitive space, again, didn't have frontline Bev and is not BRCA. Matt, does that patient need chemotherapy Bev, a la Oceans in 213, or need chemotherapy PARP, a la Study 19, Solo 2, Nova, and A3?
The answer, yes.
No, but you can't do yes. I don't like that. You can't say that. That's like you telling me the Yankees and the Red Sox are going to win the World Series. It's not going to happen. Only one of them is going to win.
Actually, the Astros.
Go ahead.
No, I mean,
give me an answer.
Again, this is where we hope molecular testing is going to help to try to decide.
So what test would you use?
So if I was trying to decide on this, HRD, potentially, but I don't personally order much HRD.
So
I use their platinum sensitivity to kind of help guide.
Thank you.
And I think that may use some of the features of bevacizumab to help guide this too, especially if somebody I'm going to give Taxol to. If they're going to get paclitaxel again, carboplatin, paclitaxel, bevacizumab would be my go-to regimen.
Because of the OS benefit in GOG 213 colon.
Correct. And I think that probably would win out on somebody that was really kind of a wild type person, as you suggested.
Chemo Bev, go ahead.
And so I agree. I completely concur. I use carbotaxol Bev in very certain clinical situations where the decision is, you know what, yeah, we're going to use carboplatin paclitaxel, and I know that patient's going to be able to tolerate the addition of Bev. I mean, I would also bring up in certain circumstances when, patient, maybe she has existing hypertension or she's got underlying renal dysfunction, maybe her counts are not so great, to also incorporate that platinum doublet, sort of the old-fashioned carboplatinum, pegylated liposomal doxorubicin or carbogem, with or without thinking about a PARP inhibitor, without thinking of bevacizumab. So, I mean, I think it's important. Yeah, so I think it's important that this decision is very personalized.
But
you talked about
what bias do you bring to the table? What side of the fence do you sit on?
So I think it's am I going to use with paclitaxel with carboplatin? Yeah. I would consider bevacizumab because of the OS. If I'm going to use carbogem, I'm probably not going to use Bev.
Okay.
For my bias is towards personalized medicine. So if I have a patient who's completely wild type, I'm going to treat that patient with bevacizumab because I want that patient to live longer, and I want to get that OS benefit. And I know that if I treat them with a bevacizumab-containing combination, they're more likely to get to maintenance, right? So we see a higher response rate.
Response rates goes from 50 to about
80, almost
75,
80%,
77.
right?
Yep.
So that in the patients that get the bevacizumab, so then I can get that patient to maintenance.
Go
and
ahead,
if I
Dave.
don't give them that combination,
But actually, Shannon, I'm going to bring up another point.
Yeah.
So that point is, if you're following someone's CM-5 and they go from like 10 to 20, and you do a CT scan and it shows, some peritoneal nodularity, and she feels fine, I find it hard to expose her to a lot of medications.
It's also true.
Yeah.
It's a good thing.
So,
but I'm trying to simplify things.
Yeah.
I will simplify it for you, Dr. Monk. Even though observation or continuing cytotoxic is a reasonable option, you're going to make me choose. 18 months, you said, of treatment-free interval, platinum-free interval, correct?
Yeah, in that range.
That's, in that instance, the time they're going to have to be on Bev maintenance may approach 18 months, probably not, but about that. That's a lot of cumulative exposure. I once again worry about the cumulative toxicities of Bev in this scenario. Very reasonable option, but I do think we are now in the age of biomarker.
What biomarker?
So I'm going to do a germline and somatic. You had it, it's wild type. If the somatic was also negative, and 40% of these will have something.
Negative. If it's BRCA
My
negative.
only opportunity to give that patient PARP is right now in the platinum-sensitive maintenance setting.
It is 2 to 3. Yeah. That's what I think. I think in the germline normal and somatic normal, Bev naive patient, which is what we're talking about. If she responds to platinum, this is your only chance to use a PARP inhibitor. it's your only chance. And so you might as well use that because these patients are going to get all these drugs, and let's use it now, and we can give her Bev later. We agree. But it's 2 to 3. Just saying.
I mean, I think
Usually Shannon's right when we
But
argue.
I would just say, you know, I hear what you're saying. Right now, at this very moment,
That's where I live, is
That's
in
your
the
only chance. But you're looking at a couple months benefit and progression-free survival across the different.
3 or 4?
If in the exploratory analyses, when you tease out each of these trials and you look at that completely biomarker negative,
gotcha.
that completely wild-type patient, you're looking at a few months progression-free survival.
Just like
now,
Bev.
if
What was
you
the
look-
platinum
let me-
Just like Bev.
Let me
Just like
finish.
Bev.
Let me finish.
Yes, ma'am.
So if you look at Joyce Liu's beautiful data with the combination of olaparib and cediranib, if you tease out that population that's completely biomarker negative, you're getting a pretty impressive progression-free survival
Not labeled.
benefit.
I want to
Not
stay,
labeled,
but you guys, listen, to talk
we
about a
gotta take it
biomarker
step
that
by
I don't have,
step.
to talk about a biomarker that I don't have, or an indication that isn't labeled, it's some level.
But Brad, I would take issue with you saying you don't have it available because you could do it after third platinum response as well.
could.
And that
Yeah,
patient's
you
going to get a response to her second line, and you have an opportunity to give her it after
But it
third.
gets less and less and
It
less.
is less, but I would say it's
So
not
let's
off
change
the
the
table.
scenario. Let's change the scenario. Let's say still BRCA negative germline somatic. Let's say if she got Bev frontline. Because you said that 218 was going to change your practice. Does that just now make it easier? Now, okay, now fine. Or are you going to use Bev after Bev, and the three of you Bev after Bev and still not use PARP?
We don't know. I mean,
don't know.
we
have no
certainly,
data.
there are
But
data.
there's no-
There
I
are
know,
data,
right.
you know, Rob Coleman presented data out of
don't know.
213 that the patients that had Bev in the front line, there was a
10%,
smaller proportion.
10% of them had
that,
Bev
you know,
prior.
and
So
those
Ursula's going to
patients
get her lucky coin
benefited.
out and
So
flip
I
it.
think, well, I think, you know, but Brad, we don't know what the results are going to be. We certainly, because there's no trial of GOG 218,
Right.
then followed by 213 or
Wouldn't-
Oceans
I
kind
gotcha.
of a.
Wouldn't
So
you-
I think then it's going to be even more personalized.
wouldn't-
Did she respond?
Yes.
How long was she on
Long
bevacizumab
time.
maintenance?
Long
Oh, I don't
time.
know. What's a long time?
So the label, assuming, will be 15 months in total. And when you get 15 months in total,
All right,
and
so-
it's about 24 months.
So if she stays on MEV maintenance in upfront setting for a long time, meaning a year
Yeah,
plus,
yeah.
and she has another platinum-sensitive recurrence, I would definitely consider it in my
Bev,
armamentarium.
again, interesting.
So I do want to make a couple of points. One of which is the improvement in median progression-free survival in 213 was about the same as in the PARP trial.
That's what I'm trying to say.
So you say it's only 3 months. It's the same exact thing in 213.
That's what I'm
Saying that, I do think the NCCN guidelines need to look at this and word it a little bit more carefully, which is 10 to 12% of ICON-7 213 patients had prior Bev with no data to say that impacted the outcome. So we should have the ability to treat our patients if the personalized decision discussion with the patient goes on.